Dear students, our next workshop Ambulance will be given by Jesse Delien and Tinka Gebruwers. First, they will explain what Ambuce Rescue Team is and how they work. Then, they will be talking about the team behind the urgent ambulance and the non-urgent transport, and the required qualifications. Finally, they will simulate a case where they will explain how the ABCDE protocols seems like, and then it's very important to interact with the paramedics and be sure they will be asking you guys some questions. Jesse, the floor is yours.
Thank you, Warda. Good afternoon, everybody. My name is Jesse. I am an ambulance paramedic in ART, Ambuce in Weinigem, Antwerp. I've been a paramedic for the past 6 years, and I'm going to take you on a little Belgian ambulance tour. So first, I will explain what our company looks like. So ART is the largest private ambulance company in Belgium. We have over 350 employees, over 400 volunteers, and over 150 vehicles. Our standards are quality, safety and comfort, of course, because we are working with a lot of patients, and we perform urgent, non-urgent, international events and custom-made and doctor on-call services within our company. We have 13 emergency bases with 16 emergency ambulances. They're mostly based in the Antwerp region, but we have ambulances over whole Belgium. 4 non-emergency bases with over 73 vehicles, 18 doctor on-call bases and 1 headquarter in Weinigem. We transport over 200,000 non-urgent patients every year, 1,800 international repatriations every year, and then multiple tailor-made services, for example, the medical services on Brussels Airport and other nice things. So, the emergency ambulance system in Belgium is coordinated by Dispatch Central 112. That's our emergency number. So we provide ambulances for the central, but we don't dispatch them. It's completely out of our league, and we don't do that. They have basic equipment with them, for example, an AED, bandage materials, and stuff like that. The basic first aid they can perform. They can be assisted by a MUG vehicle. The MUG is the mobile urgency group. It's an emergency paramedic and an emergency doctor who have been trained on pre-hospital situations, and they can assist the ambulance crew when needed. We usually perform our tasks with 2 paramedics. They had a basic training, and then if needed the MUG will come, but we have a small exception here in Antwerp, and that's the PIT. It's a paramedical intervention team, and they consist of 1 paramedic and 1 emergency nurse who can perform smaller tasks such as pain medication, assistance with hypoglycemia and stuff like that. The reason behind this is because we have very few MUG vehicles in Antwerp, so the doctor could stay in the hospital or on the really urgent calls, and the nurse can perform smaller tasks when needed. The characteristics of our emergency ambulances, you can see the typical Battenburg striping. Since 2 years there is a new law that states that every emergency ambulance in Belgium has to have the Battenburg striping and the yellow fluorescent color. There is a fixed price per transport, so every patient who has been transported or who has been seen by our ambulance crew will pay 60 euros. That's the complete cost, and then our company receives some money from the government as well to perform our tasks. We're equipped with the basics, so an AED, oxygen and stuff like that. We can perform basic tasks, non-invasive. So with serious injury, we call a MUG. We, as paramedics, cannot give any medication. So with patients who are in too much pain or need anything, for example, nausea, then we have to call a MUG or a PIT to assist us. But usually, when we do around 10 transports a day, we have 2 to 3 times that we need a MUG or a PIT to assist us. So the MUG, the Mobile Emergency Group, it's an emergency doctor and an emergency nurse. They work in a hospital on an emergency department, and when they get a call, they come and save us. Like pain medication, resuscitation, intubation is all for MUG vehicles. It's invasive procedures and we cannot do them as paramedics in Belgium. They can be automatically dispatched by the emergency dispatching central if needed. If the caller states that it's CPR is being performed, then they will send the MUG vehicle automatically. Otherwise, if we are on scene and we say, oh, there is too much pain for the patient, we need some assistance, and we can call backup from the MUG as well. The qualifications for the ambulance crew in Belgium. So there is a course provided by a provincial education center. There is only one education center per province in Belgium. It's 132 class hours, theory and practice combined. And then there are 4 days of internship on an emergency department as well as MUG and ambulance. If you have a positive evaluation, you will receive your diploma and a blue badge that you can perform ambulance transports in Belgium. And then it consists of basic training of ABCDE procedure, resuscitation, a lot of training and simulation, so we can do our complete best. The non-urgent transport in Belgium is a little bit different than the rest. So it's coordinated by our own dispatch central. We have 73 ambulances in Flanders and Wallonia who perform these transports. And it's usually from hospital to hospital, from house to hospital, or from a nursing home to a hospital. People who can't walk or are not mobile and need medical attention, they can be transported by our ambulances to consultations, etc. They can also perform emergency transports outside of the emergency dispatching central. For example, premature born babies or out of the whole province of Antwerp will be transported to the university hospital. And this university hospital, the ambulance from the emergency ambulance from the university hospital can't do all these transports, because then there would be too long of time that the area isn't covered. So we provide vehicles who are specially equipped for these kind of transports. Also transports accompanied by a doctor or emergency nurse if needed. For example, in the Brussels region, we have a permanent vehicle with nurse and doctor who performs transports if needed. It can be seated, supine, or in a wheelchair, and our vehicles are also provided to perform all the transports if needed. So the characteristics, there is also a Battenburg striping. It's a new law since 2 years, and we're in the phase of changing now. So the Battenburg striping will be only 1 block instead of 2 blocks, and it will be a white background instead of the yellow fluorescent color. The transports can be demanded through the mutuality by the patient himself or by the hospital. Then they will call us and we will give them an ambulance. They're also equipped with the basics, for example, an AED, oxygen if needed, but the training is situated differently than the emergency ambulance, so the training isn't as wide as an emergency ambulance. For example, on the photo you can see the neonatal transport care unit. It's a special vehicle who is completely equipped with all the necessary things to transport premature born babies. Also, the international repatriations can be urgent transports because sometimes when people, for example in France, have been resuscitated and they are now intubated, then we will go and get them with our ambulance crew and doctor and paramedic. The qualifications of the non-urgent ambulance have been changed last week. So there is a new law since 2019, which has gone into effect of starting of last week. So it's a class of 120 hours. So it's only 12 hours less than the emergency ambulance. also theoretical and practical courses, and they have an internship of 5 days on a non-urgent ambulance. In the internship, they will have to perform a number of patients. For example, they will have to do 1 dialysis transport, they will have to do 1 oncological transport. If they do not reach their quota, they will have to do extra days. After a positive evaluation, they are graduated and they will get a visa to be able to perform non-urgent transport. And they had a basic training, for example, vital signs checking, resuscitation if needed, oxygen therapy, etc. Then we are going to check our ABCDE protocol. So we have been changing to the ABCDE protocol 4 years ago. Before that we used another protocol, but the ABCDE is widely spread over the whole world, and it has been evidence-based medicine that we changed to this. So it's a step-by-step plan, so you cannot oversee anything. If you complete the plan, then you should have seen everything, and you should be ready to transport the patient to the hospital. And the most important thing of the ABCDE protocol is treat first what kills first. So if you have a patient who has had an accident and his leg is broken but his heart isn't beating, then you will perform CPR until his heart beats again, and then you can check for his leg. So treat first what kills first, that's the most important rule of ambulance in Belgium. So the basics. Just remember the ABCs, it's a nice one, especially in Antwerp on a Friday night. Airway, breathing, and can you walk to the ambulance? A lot of intoxicated people, that's widely spread in Antwerp, so that's why we use this one. So the A stands for airway, but before the A we do something really important. It's checking our own safety and the safety of the patient. For example, if we step in somewhere and it's been a drug user, he's unconscious but there are needles everywhere, then we will check if we can take the patient out instead of working in a dangerous environment. Also people who are aggressive, or if the roads aren't safe, then we will call in backup from the fire department or the police. We won't bring ourselves into any danger. After that we will do a quick ABC round. The quick ABC round is to check if we need to perform CPR or not. So when we approach our patient, we will start talking. We will ask what happened, and if the patient starts talking, then we can go on to the next ABCDE protocol, because then we know that the airway is clear, she has a breathing and there is circulation. If the patient does not talk, then we will check if there is breathing. If there is no breathing, then we will perform CPR and the ABCDE protocol leaves us. Then we will call in backup from the MUG and we will perform CPR until or deceased or ready to transport. So the first rule of the ABC is the airway. It's create a free airway. We can do it by putting in a Guedel tube. That's a performance that an ambulance crew can perform. We can do intubation, that's for the MUG equipe. A laryngeal mask is not for the ambulance crew. It can be performed by the doctor, or an emergency nurse who has the right qualifications can insert a laryngeal mask as well. Or by position, we can create a free airway. For example, intoxicated persons, we will put them on their side so they can keep breathing and have a cleared airway. If the airway is clear, we're gonna check the breathing. How is the patient breathing? It's not only the oxygen saturation is important, but also how does he present to us? Is the breathing agonal or paradoxical or anything? Are there any trouble breathing? Because the patient can breathe and maybe have a good saturation, but also be clinically not okay. Then we will check that as well. We can treat as an ambulance crew by oxygen or by aerosol. It's a medication, and the ambulance crews in Belgium cannot give any medication. The only exception for aerosol is if the ambulance is already on scene and the MUG is on the way, we can give them an aerosol if the MUG doctor approves that we can give the aerosol. If there are any deviations in the MUG or in the complete ABCDE protocol, then we will call in backup from the MUG to assist us with anything. If the breathing is checked, we will go check the circulation, not only the heart frequency and the blood pressure, but also the rhythm. Are there any heart problems in the past? Is there any retrosternal pain? Things like that. We cannot treat the patient if needed. The most interaction will be with the WUG. They can give any medication to help the heart problem. The only thing we can do is things like positionary changes and stuff like that. So if the circulation is checked and it's fine, we go to the D from disability. With disability, we are mostly going to check the neurological improvement or disimprovement of the patient. For example, the Glasgow Coma scale is frequently used in pre-hospital situations. Also Pearl, check if the pupils are equal and reactive and responsive to light. And then we use the WAPA. It's a Belgian word. It stands for a patient who is alert, is verbally responsive, is only responsive to pain, or unresponsive. So if the patient is awake and kicking, then we will score him an A. If the patient is completely unconscious, then it will be a U. But most frequently used is still the Glasgow Coma scale, because it's you can check the improvement of the patient. We will perform a fast test if necessary. The face, arm, speech, time protocol, it's to check if there is any signs of an intracranial bleeding or I don't know how to say in English, a stroke. We will check the glycemia to see if there is a hypo or hyperglycemia. If there are any deviations in this, then we will also call in the MUG to give us assistance with, for example, sugar or extra assistance. For example, people who have a Glasgow Coma scale of 3, usually we should call in the MUG, depending on the situation. If there is a Glasgow Coma scale of 3 after a big car crash, then we will also call in help from the MUG. But the person who has been intoxicated by alcohol, we will not call in the MUG, because they won't do anything as well. They cannot perform any extra things than we can. If the disability is checked, we go on to exposure. We go investigate the temperature of the patient, especially in Corona timing. It's an important thing. We will ask for as ample. It's a complete check of the patient's history and current situation. So the S stands for situation. What happened? Why did you call the ambulance? The A stands for allergies. Does the patient have any allergies to medication or etc.? Because if the MUG arrives and they will give any medication, it's important to know. The M stands for medication. Does the patient already take any medication at home, and why does he take them? The P stands for past history. Does he have any problems with his heart, with his lungs? Is there a reason why the ambulance comes now, and is it possible that it's in the past history as well? Did the patient eat? That's the L from last meal. It's important if there are given any sedatives, etc., to prevent puking. And then the E stands for event. What's the event that happened that leads to these symptoms? For example, a car crash can be an event, but also an intracranial bleeding can be an event as well, which gives certain symptoms. We go ask for the pain scale as well. It can be a VAS score, so visually with the faces on the line, or an NRS score with a cipher from 0 to 10. We perform a head-to-toe complete check. We're gonna check the patient completely. For example, if there has been a car crash and the patient says his leg hurts, we will check him from head to toe if there are any other injuries. If this is done and we don't need any extra information, and we can also intervene here to do extra things if necessary, then we will prepare him for the transport. We can do this in several ways. The patient can get in the ambulance himself. We can put him on our stretcher. We can immobilize the complete spine if necessary. That's all in prepare for transport. It's when everything else is done and we're sure that the patient can go to the hospital, then we will start the preparations. The mugarts, if he came, he will always call to the emergency department of the hospital of destination, so they are aware that we are coming and they can prepare. For example, every serious injury from example car crashes or active resuscitations where people are still being resuscitated in the ambulance will go to the university hospital in Antwerp, and they have a complete trauma crew who will be ready on arrival. That's the short presentation of how the ambulance in Belgium works. So now we're gonna show you how the ambulance in Belgium looks like from the inside, what equipment we have with us, and then afterwards we're gonna do a little simulation so we can show you how we work, and then we can interact with you as well to give us any ideas. Okay, and first of all, we're gonna take 5 minutes of break, and then we will proceed. Had maar eens beter.
Ja, stak mooi.
So, welcome back everybody. We're going to show you our emergency ambulance from Belgium right now. So, most important, in our ambulance we have a bed, so we can transport the patients in supine position if necessary. This bed is especially designed to be able to be put on a special stretcher from the fire department. If we have to evacuate people from higher buildings, etc., they can be put on the bed immediately. We have some different stuff, for example, a special stretcher to pick up patients who are on the ground and they need to be picked up on our bed. We have 2 seats for our doctor, paramedic, nurses if necessary. So there will only be 3 people in the back maximum, so 2 medical personnel and the patient himself. This is a really equipped ambulance. Normally the normal ambulances in Belgium don't have monitoring or respiration with them. They only have a small monitoring system because, for example, we cannot read ECGs. We only do blood pressure, saturation, and if necessary 4 leads to check the heart rate. So they are normally not in the ambulance, but this is an emergency international ambulance, so that's why they have it. We have an external AED because if the AED of the monitor fails, we have an extra one. We have some cabinets with, for example, a manual resuscitator, some collar bands and puking bags if necessary. We have a monitoring and the AED system completed in one, if necessary respiration system, and a suction unit. Every emergency ambulance in Belgium has a suction unit. The non-urgent transports have a smaller system which can be manually used, but it's not frequently used on non-urgent transports. We have a needle container and some small stuff. Syringe driver. The MUG always has a few syringe drivers with them, and this ambulance, for example, has one as well, but it's not frequently used pre-hospital. We have our basic systems like gloves, extra stuff. We have some blankets with us, and then we have a lot of cabinets who have the basic equipment, for example, wound packaging, oxygen therapy, wound dressing if necessary. Also, since the 2016 attacks in Paris, we have a specially designed terror kit which has tourniquets and Israeli bandages, etc. We have our personal protection equipment. Since the corona timing, we use this a lot. masks, FFP2 masks, and extra gowns if necessary. Also basic equipment like pupil light, glycemia setting, and temperature measurement is in this cabinet. Then we have an extra cabinet because this is an emergency ambulance. We have basic lining equipment to give medication if necessary, and then some sanitary stuff and extra equipment for the ambulance. For example, if our suction unit is full, we have some extra stuff. Intubation, but this is not frequently used because the MUSH always wants to use their own stuff because they know their own stuff better. We also have a specially designed bag which contains all the material we need: wound packaging, oxygen therapy, manual resuscitator if necessary, and material to take the blood pressure, the saturation, etc. is all inside our bag. So if the patient cannot walk to the ambulance himself, we will take the bag and measure everything what's needed. Out here we have oxygen therapy if necessary. These are medically purchased, so they can only be used in ambulance and pre-hospital settings and not otherwise. I will take you back to the back of the ambulance to show you the other side. On this side of the ambulance we have some storing equipment. For example, our fire extinguisher. We hopefully don't use it. It's not to extinguish fires, but it's necessary if our own car is on fire, we use it. We have some extra oxygen for the ambulance itself, and then we have a carrying chair. For example, people who are on the second floor of a building and they need to be evacuated and they cannot walk themselves, then we will take them on our carrying chair and put them down the stairs. Spinal immobilization, it has been frequently used in the past, but now since a few years there have been votings to quit with the spinal immobilization and put them on our other stretcher with the head blocks and just tape them. There has been a study from the University Hospital in Antwerp and some other studies in the United States who have been saying that this is not the right equipment for spinal immobilization. We have some extra immobilization for possible fractures and then immobilization for the spine if a person is trapped inside a car. Then we can evacuate him with these extra immobilization without damaging the spine extra. Then I will show you the front of our ambulance. This is a basic front, so we have a GPS. The central dispatches the location of the intervention automatically to the GPS, so we only have to get in and leave. And then we have a tablet for the non-urgent transports. They get their transports through to the tablet, and then they can leave, and they can also update the dispatching central where they are and if they're with the patient, en route to the patient. They also have normally a walkie-talkie we can talk to the dispatching with, but this ambulance is not equipped because it usually does the international transport, so we don't use it on the emergency central. So that's how a Belgian ambulance looks like in short. We can also, if necessary, put extra equipment in. For example, a special mattress if the patient has decubitus, etc. It can also be modified by the wishes of the client. For example, our Brussels Airport rescue team has a special vehicle with special equipment because the ambulance from the airport uses different equipment than other ambulances. So we also discuss it always with the patient and with the client if necessary. So now we're going to take a short break of 5 minutes again, and then we're going to show you how we work as a team to help a patient out.
Die zijn gestopt.
Bicycle by a car, and we will show you how we work as a team now. So first of all, we have the ABCDE protocol, but safety first, so that's why we take our gowns and also check if there is no other transport on the road, etc. So my colleague, the first thing she will do is a manual stabilization of the neck, because the patient has been hit by a car. We don't really know what the problem is yet, so this is why we will first check this. She's awake, she's crying, so the first ABC is okay. She has a circulation, she has a breathing, the airway is clear because she's crying. So first thing we will do is check if we need to keep the manual stabilization of the neck. Miss, I'm Jesse, I'm from the ambulance. How are you feeling?
My arm hurts.
Okay, the left or the right arm?
The right.
Okay, do you have any pain elsewhere?
No, it's just my arm.
Okay, does your neck hurt?
No.
Okay, do you feel your legs?
Yes.
Okay, can you
My
wiggle your
arm.
toes for me?
Yeah,
Okay.
it's okay. My arm.
There is no neck or back pain. The toes and the arms are both mobile, so we don't expect a spinal injury right now. So that's why my colleague can leave the neck as it is. And then we're gonna see the ABCDE protocol. So A, she has a cleared airway. She's awake, she's conscious, so she can clear her airway herself. Then we're gonna check for the breathing. So we have a monitoring system right now. We can use it
My arm.
to check for a saturation.
Ah.
And then my colleague is gonna check for a breathing. She's gonna put her two arms on the chest of the patient to check if there is an agonal breathing or normal breathing or anything different. Miss, we're gonna do a little checks, few checks, and then we're gonna check your arm.
Oh my god. My arm.
Okay, try to breathing slowly, okay? Try to keep calm.
Was that the car?
Okay, so right now we're seeing she's breathing normally, maybe a little hyperventilation, but that's okay because if she's been hit by a car, it's normal. A good saturation, and then we can move on. So the breathing is okay. Then we're gonna check the circulation. We're gonna go with our heart frequency of the monitoring system, but also we feel. This is the painful arm?
Yes.
Okay. So we also check the painful arm to check if there is any perfusion to the limbs, because if she broke her arm here, there is a possible rupture of any blood vessels. So we also check the good arm and then the bad arm, the bad arm and the good arm. So we can feel her pulse. It's normal. It's regular. and she will probably have a good blood pressure because I can feel it here. But we also check it always. Blood pressure management always on the good arm.
And also my head hurts a bit.
Your head hurts a little bit? Okay, we're gonna check in a minute. Okay. Do you have any heart problems?
No.
No? Okay, perfect. In the meantime, we can complete the C and we can go on to the D. This is the most important in this case. She has a good Glasgow coma scale, we can see, but the pain scale, etc., is important in this case to see if we need assistance from a mug or we can do it on ourselves. Okay. So, how much pain do you have on a scale from 0 to 10?
6.
6, okay. Usually we see more than 8 or more than 7 is a mug, and less than 7 is we can do it on our own. But it's also the clinical image of the patient. Right now, she has a possible fractured arm. We can do it ourselves. We don't need the doctor to come here to check it out. Okay. So the D. Also, we are checking a glycemia, but we don't do it always because in this case there is no internal affair, there is no problem. The problem is clear that the arm is broken or severely damaged, and there will be no right problem with the glycemia. But we also asked, did you eat anything?
Yes, in the morning I ate breakfast.
You ate breakfast, okay. Are you a diabetic?
No.
No diabetes, okay. If she's not diabetic and she ate well, then we will not perform the glycemia measurement. Then everything neurologically seems fine right now. And then we're gonna go on to the E from exposure. So temperature management is really crucial right now in Corona timing, so we will take her temperature. And then we're gonna do a head to toe checking. Ik ga best nog een beetje aan de kant gaan.
Een beetje opschuiven.
Okay, so my colleague is going to measure the temperature. In that zwarte zak.
Zwarte.
And in the meantime, I can do my assessment of the patient. So, ma'am, how are you feeling right now?
Only my arm hurts.
Your arm hurts. Okay, so a pain
much.
scale of 6 is still.
Yes.
Okay, perfect.
Can you bloeddrukken?
Yeah, okay. Do you have any allergies?
Only for penicillin.
Penicillin. Okay, perfect. Do you take any medication at home or on a regular basis?
No.
No. Okay. And
Sometimes paracetamol,
but not on a regular basis. Okay, perfect. Do you have any past history of medical problems?
no.
No heart problems, lung problems?
No.
Okay. Any surgeries on your arm?
No, never.
Okay, perfect. You ate breakfast? What did you eat for breakfast?
I drank coffee and I ate and I ate pancakes.
Pancakes,
chocolate.
okay. And then you have been hit by a car now.
Yes.
And how fast were you cycling? Do you have any idea?
Not so fast. It was like 10 kilometers.
And do you have an idea how fast the car was driving?
Yeah, it seems like it was 40 kilometers.
Okay.
Normally I don't know, it was like 40 kilometers. It seems very fast.
Okay. And you always have gained consciousness? You haven't been unconscious?
No.
Okay. And you know what happened with the car accident? There is no blurry image?
No, just my head hurts a bit, but...
Okay. You're not nauseous? No vomiting? Okay. I'm gonna check your eyes for a second. Look up. Okay. We always check the pupils to see if there is any neurological problem. So dilated pupils or unequal pupils can give a sign for neurological problems. So my colleague is going to perform a head-to-toe check to see if there is any problem besides from the arm. Adrenaline in such situations can give a situation where we as an ambulance crew miss some certain things. So she's gonna touch everywhere and she will say it. If you have any pain, then you will have to say it. Always check the belly to see if there is a possible internal bleeding. Okay, we're not gonna check the arm right now because we know that the arm is already compromised. And then we also check everything completely. If this has been checked, then we can move on to our last thing, and that's preparation for transport. Since she has a possible broken wrist, because it's the wrist that hurts, I think, yeah?
Yes.
Okay, then we will immobilize the wrist with our vacuum system. So this is a special system we use for wrists. We have different sizes of the vacuum systems. Since the patient is stable, we don't need a continuous monitoring of the vital signs. It's okay. Can you lay your arm down?
Yeah, I will try.
Okay, we're gonna put a little pressure on the arm so we can, if there is a fracture, separate it from the both bone fragments. My colleague is going to keep the pressure on the arm right now. And then we're gonna close it. When we close the vacuum spout, it will be less painful because you can't move your arm anymore.
Okay, thanks.
Always be sure that you can still see the fingers if there should be any problem and they become blue or things like that, then we can check, but they should always be visible. So this is our vacuum pump. We close the vent. Okay, so now you can feel it press a little bit.
Yeah.
Okay. And when I pull the vacuum, I pull the air out, my colleague is going to slowly release the hand of the patient and pull her hands out as well. So now it's approximately halfway there. We're gonna form it around the arm. Pull the strings again. And then we're going to completely suck all the air out. Is it less painful now?
Yeah, a little bit.
Okay, perfect. Much better. You can move your arm now, it's no problem, and then you can try to put it on your belly and support it with your good arm. Okay? I'm gonna help you. Okay. Then we're gonna put the patient up and see how her reaction is. When we put up a patient like this, she has been down for approximately 15 minutes at least. We also check the blood pressure again. If we have a radial pulse which is good and we can feel it, then we know that her blood pressure is high enough to put her up and walking to the ambulance. If the patient in this case couldn't be walking anymore because she has a broken leg or things like that, then we take our stretcher. We transport her to the hospital where she has an x-ray, some pain medication, and then we'll see if there is any surgery needed, but that's the doctor's case. Okay? Super. We thank you for your attention, and we hope you have a nice idea how the ambulance in Antwerp and in complete Belgium works now. And hopefully we see you again for the next workshop.
Thank you very much for the good help.
Camera staat toch even nu?
Daar gaat van hen af. Ik ga maar sfeerbeelden tonen. Oké. Maar ze hebben de stream normaal gezien al afgezet. Hè. Dus ja. Ik zal nog de ambulance tonen.
Ja.
All right, the students have now the possibility to ask some questions. I'm now going to read some questions for Jesse. Okay, so the first question is, what are you giving by my aerosols?
Usually we give medication like Ventolin or Duovint by aerosol. It's a combination preparation of anticholinergicum and beta-mimeticum to increase the airflow and the oxygen support in the lungs.
All right, thank you. The second question. In the Netherlands, we have special ambulances in which surgeons remove donor organs from a deceased patient. How is that arranged in Belgium?
We do not have special ambulances, but every hospital who has a possible donor or patient, we call them the harvesting patients, they will call their own surgeon in the hospital, and they will perform the surgery themselves, and they will be transported in special vehicles, some motorcycles and some specially designed cars to transport the organs to the necessary hospitals and the necessary patients.
Okay, thank you. The third question, how is a patient with hypoglycemia managed?
Hypoglycemia, it depends on the patient. If the patient is awake and he is known with diabetes and we see lowered glycemia, then we can give him cola and sugar. For example, we give fast sugars like Coca-Cola or anything like that. Usually Fanta works better because there is more sugar. Otherwise, we make them a sandwich with some stuff. Choco, for example, which works on a longer period, and then they will check them themselves. If this is not possible and the patient is unconscious, then we will call a MUG service or a PIT, and they will come and give glucose by intravenous access. And then when the patient awakes, we also give them a sandwich with choco or anything.
Okay, that's fine. Then the fourth question. There are people that would give a 9 on the pain scale while only having a broken wrist because pain is relative. Do you acknowledge that, or do you always call the MUG when the pain scale is that high?
It always depends on the situation. In the case we just presented with Warda, her broken wrist, if she would have answered a 10, I would have probably not acknowledged and not have called the MUG, because giving pain medication and taking a MUG away from its service for this is quite expensive at first and quite difficult, because other patients cannot receive the MUG when they really need them and not for the pain medication. So it always depends on the situation and the patient, but in this case I wouldn't have. I don't always acknowledge a higher pain scale.
Okay, that's fine. Then the next question. All right. In the case of calamity or natural disaster, what role does the Ambuce rescue team play? How does it help to mitigate the loss of life, and does it operate any rescue mission?
It also depends on the situation. For example, we have Ambuce is not the only firm who performs emergency transports. For example, the fire department in Belgium does a lot, and other private companies do as well. So when there is, for example, a disaster in Antwerp, we have het Sportpaleis, for example. If there is an explosion in het Sportpaleis, it's a large theater with over 30,000 places, then the first help would be 10 emergency ambulances, and they will be from every firm. It will not only be Ambuce, but also the fire department. The most nearby ambulances will be handpicked by the emergency central. So if it's an Ambuce ambulance, of course we will respond. And extra to those 10 ambulances and 5 MUG services, they will call in help from the Red Cross. The Red Cross has in Belgium a system designed for large disasters and first help. they will come with all the necessary ambulances. In a large case, for example, if the Sportpaleis with 30,000 people would explode, then there will be also 10 ambulances from the nearby provinces. For Limburg, Brussels and Oost-Vlaanderen will send some ambulances as well. And then Ambuce will call to the emergency dispatching central. We had explosions in Zaventem a few years ago, and that the ambulances from Brussels would do the first aid, and then there have been some extra ambulances sent from Antwerp from the emergency systems, and Ambuce called and the emergency central and said, "Oh, okay, we have 5 extra ambulances we can make free. We will give them to you and you can use them." In other cases, for example, the tsunami in Thailand a few, I think more 10 or 11 years ago, Ambuce will provide, if necessary, medical services. For example, our CEO, our big boss, Jan Christian, went with the medical team to help out and do a humanitarian mission. And if requested, we can always help out. It's usually we have in Belgium a BFAS team, which Ambuce rescue team isn't part of, but if necessary, with really large calamities, we can always help.
All right, thank you for your good explanation about that. Then the next question. When the patient just hurts his or her head, how do we manage that? What are the things we have to do when the patient is alert and awake? And what do we do when the patient is not awake?
When the patient is not awake and he hurt his head, it's always a MUG indication. Unconscious patients are actually always a MUG indication. But we have to use our common sense. If it's in a nightclub and it's just unconscious because he drank too much, then we will not call the MUG and we will do it on our own. But an unconscious patient who hit her head is definitely a MUG indication because there might be a neurological problem. If the patient is awake, it depends on the situation. We always ask for signs of a commotio, for example, nausea, photophobia, vomiting, and more specific explosive vomiting. And it always depends on the situation. How hard did she hit her head? Did she hit her head because she stumbled on the normal ground, or did she fell from a chair or a table or anything? Always depending on the situation.
Okay. All right. Then, how does the Ambuce rescue team deal with medical legal aspects of an emergency case? An example: a road traffic accident.
We, as paramedics, have a medical in our medical profession. It's in every country, I think, a medical secrecy, which we cannot violate. For example, if we have a car crash and one person appears to be drunk, it's not our task to call for the police. We have a medical secrecy. The only case in which we can call the police is when the patient is threatening to hurt himself or is threatening to hurt other people. If the patient states, "Oh, I'm gonna plant a bomb in the University of Antwerp," then of course we can call the police, but in other minor cases it's not our deal. For the example of the road traffic accident, every accident in which an ambulance is requested because of a patient who is injured, there will always be police on scene. And if one of the patients asks for police, we can always request them, but we cannot request them because we have hunches of intoxication or anything. For example, we had a burglar yesterday on our emergency department, and we cannot call the police because we know he was a burglar. We have to treat the medical aspect, and that's it. If there is another person there who says, "Oh, he's been burglaring in my house," then it's his responsibility to call the cops.
Okay, thanks. Then the last question. In my country, tetanus injection is given to every injured person involved in an accident. Does this happen in Belgium too?
It only happens when the patient isn't sure about his vaccination, or if he doesn't really know. Maybe I had it, but I don't really know for sure. When he's sure that it's been longer than 10 years. If he's sure, okay, I had it last year, then we don't give it. If he's not sure, or there is a possibility of doubt, then we give the injection.
All right, thank you very much, Jesse. If there are any questions, then it's now the moment to ask them. Are there any questions? Yeah, okay. Okay, then this was the workshop ambulance. I will, special thanks to the two paramedics, Jesse Delien and Tinka Gebruers, for the good presentation and for the simulation. So thank you very much, and have a nice day.
Thank you.